respiratory training is not respiratory training. It's not what a lot of people are saying that it is or promoting, but actually using a device in a very particular way with the right dosage to cause the change. Resistance can only be, as the guys in strength training now know, you can only add that type of load after the movement quality is there. You should always honor the people that have moved us to this point. And if it wasn't for them, we wouldn't be discussing it in the first place. So, respect to everybody that came before me. Quit being a chicken shit. If you want to know they're not going to be injured, then try and injure them. Let's keep people out of the medical system because it's already overloaded. It's expensive. And stop thinking that they are not in control of improving themselves. No, we can't continue to do it this way. I understand why universities do it this way so they can publish and compare, but it's not how we do it on the ground.
Welcome to this new episode. Before we get started, I'd like to thank our sponsor for the podcast, Moxy Monitor. If you've been following my work, you know that the Moxy is a tool that I use a lot for testing, but also for everyday training and coaching. For those who don't know about the Moxy Monitor yet, it's a NIRS device that measures muscle oxygen saturation and blood volume in real time. It's a non-invasive sensor that is placed on the skin and can be worn during any training or sporting activity. Motocross riders and climbers wear it on their forearms. Hockey players on the ice, swimmers can wear it in water. I've used it to test rugby players, CrossFit athletes, endurance athletes, and more. The Moxy allows you to individualize work and rest periods, optimize load, reps and sets, identify training thresholds in real time, and even correct movement based on what the data shows you. You can also use the Moxy Monitor to determine an athlete's energetic limiting factor and their individual training zones. Using this process, I can now target the athlete's limiter with precision in order to improve their performance without adding unnecessary volume to their program. You can view and collect the data on your Garmin watch and can also pair the Moxy with other physiological testing products such as the VO2 Master, PNOE, and Cosmed VO2 systems. The Moxy is a product I've been using for many months with great success, and I highly recommend it to any coach who's interested in digging a little bit deeper on the physiological side of health, fitness, or performance. You can use the coupon UPSIDE at checkout for a 5% discount on moxymonitor.com/shop. That's UPSIDE, UPSIDE, for a 5% discount. With that said, let's get into the show. All right, Daniel, we're live on the podcast once again. How you doing, my friend?
Hi, Sean. Good to talk to you again. I'm doing well.
Yeah, always good to have you on. For those who don't know Daniel, please go check out the 2 previous episodes that we recorded together. They're available anywhere that you might be listening, Spotify, Apple Podcasts, YouTube. Daniel, to start things off, I wanted to talk a little bit about you. You recently moved back to England from Greece, where you were for quite a while. How's that going for you?
Settling in. Yeah, just as you know, it takes a little bit of time, and then I have to go through the whole immigration process again as a Canadian. So
yes,
but it's a lot easier to do in the UK, that's for sure, as a Canadian, as a ex-Commonwealther. So, but it's also really nice to be able to connect with so many users in the UK,
right?
And to be located in Chichester University here. So it puts me with a lot more access to be able to directly interact with people using PNOE or P100.
Yeah, that's really good. How's the weather compared to Greece? I'm sorry, I had to ask.
Well, I guess the way I describe it, the way my wife does it, there is weather here, and there is no weather in Greece. It's just sunny and warm all the time. So, it changes pretty well every 5 minutes. So it's but I think it's lovely. Love the sense of community here in England. Living in a relatively smaller town, and that's part of the reason we moved here was to try and establish that sense of community.
Were you in a bigger town in Greece, or?
Yeah, we're in Athens, and then before that Beijing, and then you do 29 years in the army and you're moving all the time. There is no sense of community except for the army itself. So it's something that I realized that I would like to do is to stick in a place for a little while and just work out of there. And luckily, with my connections that I've created over the years, I have the ability to kind of work where I wish and interact with people internationally that way.
Yeah, that's really nice. You were talking about finding a sense of community again. Is there anything you have in mind in terms of creating some events or some get-togethers now that you're local to England to try and further that?
Absolutely. I think I'm really pushing forward the module 5 of the certification program.
Hmm.
There's a lot of people that want the 4-day practical course,
Hmm.
and I realize that in some ways now that I've been running my course for about 2 years, is that I could kind of skip people forward more quickly. Once they've done modules 1 to 3, I could just kind of move into 5 self, like all the testing that would go on,
Hmm.
because my intent is we'll use metabolic analysis, near-infrared spectroscopy, in addition to respiratory training using different devices.
Hmm.
So I'm in conversation trying to convince not just IDEAG has the P100 is the best respiratory training device, but an option for those that can't afford it. So I'm trying to work with other companies to be able to provide something in the middle
Hmm.
for those people, because I'd rather not provide no option. It just it drives me crazy to be able to teach how to find them and how you have to train them, and then have no device for them to use. So I've had conversations with I won't mention their names, but the 3 or 4 other hitters in the market, and I
Hmm.
think I found a company that is willing to kind of listen to my bizarre ways of approaching respiratory training. When I talk to people, it's sort of like, well, this is much more in depth, much more systematic, and that's where respiratory training needs to go. So we'll find out if I can find. IDEAG's been fabulous about listen to me blather on about my recommendations and incorporating them. Let's
Hmm.
see if we can find another company so that we can get even more people, especially with COVID, being able to deal with the respiratory limitations that are left over to get them up to function or up to performance again.
Yeah, that's a really important point I think you bring up is the leftovers from COVID that a lot of people have been experiencing. Even, some pretty high level athletes I know a few that are in, the best shape of their life. They're doing really good from that standpoint, but it didn't prevent them from having some side effects following COVID. Did you have a lot of experiences with this since this whole thing started yourself?
Absolutely. Yeah. Then the number one issue is respiratory capacity. And it hits capacity hard, but it hits capability even much harder. So for those that don't know what I mean by the difference between the two, so standing still, your actual lung volumes measured through spirometry
Mm-hmm.
will be affected. And it tends to affect both inspiration and expiration fairly equally. But when they start moving and during a metabolic analysis test, their ability to use the volumes that they have, although limited, are even limited even more.
Mm-hmm.
And therefore, the training needs to be different with those guys. I am finding that they do respond very well to respiratory training.
Yeah.
And again, I'll just hammer away on the respiratory training is not respiratory training. It's not what a lot of people are saying that it is or promoting, but actually using a device in a very particular way with the right dosage to cause the change.
Mm-hmm.
So what we've got to do is start talking about respiratory training like we talk about resistance training.
Yeah, which is really one thing that I've learned from you from the early days, and now you've formalized this in your. You talked about the metabolic analysis certification program that you've put together for PNOE. It is accessible to PNOE users, but now it's also open to outside users who maybe use other devices and who want to learn. We'll come back to that certification program. I've been going through it myself. I'm getting close to finishing the exam of module 3 and looking forward to the next segments, but definitely something that you've brought, I think, to the table, and rightly so, is, like you said, that structure around respiratory training and not just seeing it as something fluffy. And I mean, the vision that I had of it at the very beginning when I first heard of it, it was very quote unquote confusing for me. I was like, okay, well, how does this thing work? But you've done a great job, I think. Like you said, structuring it, making sure people understood the difference between, you talk about capacity and capability. I talk about capacity and function, just because function kind of speaks to people when it, not to go functional on people, but it's simply the function of using your capacity during a dynamic effort. And like you said, it's really, we're playing with the same parameters as strength training, as even endurance training, but it's just specific to the respiratory system. So once you have that basis of understanding of what is spirometry, how do you measure lung capacity, how do you measure expiratory power, what does the ratio mean? Now you have a basis to understand how to apply those things methodically and not just haphazardly, like, again, I thought in the beginning, right?
Yeah, and it is confusing to people because there's tons of people writing about it and talking about it. But it's funny, after I had gone through and formalized the structure, and like I've been working since about 2006 on respiratory training differently than everybody else. There's a few other people out there with some good ideas that we all kind of grew up together. But you realize that, if you look at respiratory capacity, it's what a lot of people would refer to as movement. Getting diaphragmatic mobility and thoracic and rib mobility will give you, and then getting the neuromuscular function of the diaphragm and your expiratory muscles to work. So it's really all about movement and mobility. And then comes in, are we doing resistance, but what type of resistance? Is it power, or is it strength, or is it endurance? And as we hopefully know in resistance training, even though it's still very confusing about what the difference between hypertrophy and strength endurance and power is, in resistance training, it ends up looking very similar. Yeah. The number of times per week, the work to rest ratios, the level of resistance, all that stuff, you end up feeling like what you're doing is writing a resistance program. And that resistance can only be, as the guys in strength training now know, you can only add that type of load after the movement quality is there. Yeah. So I now am looking more at respiratory capacity as a movement mobility portion of it as well, if it fills that role. Yeah, which makes sense. You have to know how to use your respiratory musculature in general. You have to know how to move your diaphragm. You have to know how to maybe not use your traps to do all the work and those kind of things. So like you said, movement quality first before you start applying heavy resistance to it or add endurance to it. It would be, it comes back to, just like you said, before you want to, get a CrossFitter to do 100 air squats or even back squats under fatigue, you need that movement to be sound, because if you don't, then you're not going to get as good an adaptation from the training, and you risk further trouble down the line. One thing that sticks out for me with respiratory training, with the few people I've been lucky to apply it with, is the fatigue that it generates the first few times that you partake in, and really just focusing on your respiratory system and training it. Why, in your opinion, why is that the case? Why is it so fatiguing to work your respiratory musculature when really, if you think about it, it doesn't seem like they're, big movers, big muscles, although the diaphragm is pretty significant. But it's not like, it's not like doing a back squat. It's not like doing a deadlift. Why is it so fatiguing to train your respiratory system? I think any type of neuromuscular training is always more fatiguing, right? Especially if not done before. It adapts quickly. But yeah, that first 3 or 4 workouts and just kind of understanding how to put everything together, it's much more neuromuscular. And once you get that engagement going, it's amazing how quickly, in fact, it's hard to keep up with your athlete. You have to constantly, as soon as they achieve, move. And this is where the coaches need to understand where's the point in which to move this person. And, I talk about having 6 different plans outside of strength and endurance, for respiratory training. And I just got off the phone with another person who has achieved a majority of the respiratory capacity gains, but has a race in 8 weeks. So we established that the race would take place in zone 3 and 4. So I built a pyramid program for 3 and 4, trying to maximize her capability, her ability to use her current capacity in that race. And that's the type of way you can manipulate this information. And going back to your question, it does not take long to be able to make those connections on a normal individual. So, in some cases, you could look at how important would be respiratory training with somebody with a spinal cord injury. Depending on the level, trunk stability is a huge issue. And it gives them a huge amount of function peripherally if they have huge trunk stability. Yet there'll be damage to the nerves serving the diaphragm and the respiratory muscles. I think this is a real lost opportunity to use respiratory training with other populations than what we're thinking, not just for function for a normal population to be able to do what they wish to do, or for athletes for performance. But if you're thinking trunk stability is important, then you should also be thinking train the respiratory system, because there's no better way of training, let's say somebody with a chronic low back issue. Using respiratory training is absolutely brilliant for actually increasing trunk stability and decreasing low back pain and improving function.
Well, can you kind of talk us through the, I guess, what the adaptations or what the effects would be of respiratory training for someone with, let's say, low back pain? Why would it be beneficial to them? In what way is respiratory training going to improve trunk stability, et cetera?
Well, I mean, you can go and say, what is the relationship? What's the correlation between respiratory function and incontinence or low back pain? And there is plenty of studies that show that there's decreased tidal volumes with these people. They just, because of their lack of pelvic, it's the way the pelvic people talk. I'm trying to talk the way that they talk about, but essentially their ability to engage their pelvic muscles and their diaphragm, secondary to, let's say chronic low back issues or pelvic pain in the case of women's issues. By increasing tidal volumes, we know that we can increase spinal stiffness and stability, and that will decrease pain and increase function. So what you could, I'm just going to reverse engineer and say there is a relationship between respiratory function and these two conditions. And it's going to be related to the neuromuscular and strength and endurance around the diaphragm and pelvic muscles. And what a great way of being able to train them that would also be able to reestablish the mobility of the diaphragm and thoracic and rib mobility in conjunction with helping decreasing their pain and improving their function specific to their deficit.
Yeah, one thing that I've definitely noticed is, and I mean, anybody who spends a little bit of time focusing on how they breathe, even in a fairly quiet setting, like even in a supine or a quadruped position, just by directing the breath into different parts of the back, for example, and just really focusing on moving the ear in and then feeling the tension and then moving it out, you can make some significant mobility improvements just by breathing in different spots without, and I know you talk about going to end range and then breathing there, which works really well as well. But I've seen even without going to end range, actually using the end range as a test retest, and then getting people to breathe in very simple positions, but actually focusing on, okay, can you breathe into the upper third of your back? Okay, that works well. Middle part, not so well. Okay, let's take 10 breaths here, and every breath you try to add maybe 5% of air that you bring in. Low back, oh, okay, no air is going in here. You feel like you have 40% capacity versus what you could do at the top. So we spend a bit more time there. Next thing you know, on a simple sideline kind of thoracic opener or something like this, you can gain 20 centimeters of hand movement or shoulder movement just by going through that breathing process So back to your point, just really, I guess one part for me that's really interesting above all the training effects is just the amount of control that people can gain on their movement and on their breathing by just focusing on it just a little bit more than they usually do.
Yeah, and you just need, in some cases, you need some kind of neuromuscular input. They need to feel some biofeedback to be able to understand what you're doing. There's some people that will just get it, and they'll be rare. And then you'll get the, if you get a guy in there that just likes to pick things up and put it down, they'll need biofeedback. So this is where, positioning makes a huge difference, right? Giving them something to be able to feel that they're pushing against. But I love bands for this.
Mm-hmm.
Yeah, just trying to get them to understand the concept of, everybody talks about breathing vertically, and you're going, yeah, I understand that. But diaphragm needs to go down, so it don't make it sound bad. But by simply putting a band around the area which you want them to expand, and ask them to stretch that band as much as possible, it will give them the feedback necessary that they can do on their own, because there's lots of ways of doing this manually yourself in clinic, but you've got to give them something to go home with as well. So I love using some of the thicker bands to give them lots of biofeedback.
Yeah, no, that's a great way of doing it. This is something I've been using with the Spire Tiger and then the P100 as well. Even just seated on a chair and having a band pull you from the front. That was kind of the intent, was to breathe into your back a little bit more. I think that's also an underappreciated aspect of breathing. You talk about, like you said, breathing vertically. So we want the diaphragm to depress and go down and open that chest cavity. But we also want to leverage our back, because often we breathe in front here with our chest, but we don't go into our back, when really that's where all the space is. And we could change a lot of things back there as well by breathing better into there.
And I think that's the reason why tidal volumes are limited with people with back pain. Yeah, is that, and you can just really work really good mobility down there, but you can also get really good engagement as well of the back muscles themselves to actually be able to open up the spaces, and for sure. And the issue that exists right now is the majority of respiratory training devices right now have resistance as being their focus. And while that plays a role, it's a lot better now, because you can set the resistance down low, and you can have resistance on inspiration and expiration, which is good. Mm-hmm. But the real trick at the beginning is just getting that mobility going, and be able to know that you're moving the volumes that you need to be able to move.
Yeah, I think that was one of the most eye-opening things for me once I was able to add the respiratory data to my testing protocols with the VO2 Master in that case. But just seeing how people breathe during an effort gives you so much more information. Spirometry is definitely the first step, and I learned that from you, so you can interpret the data that you collect afterwards. But just seeing how someone breathes, and how, honestly, from what I've seen, the small sample that I've seen so far, most people do not leverage their volume at all, and they're fully frequency based, and they're walking at 5 kilometers per hour and they're already breathing 30 breaths a minute. And then you see them just escalate and hyperventilate at the higher intensities. And even just on that aspect, having someone just focus on their breathing, on a bike, something simple like put yourself at 80 RPMs and then couple your breathing to the pedal stroke so that you can stick with, for example, 20 breaths a minute, and really just work on how much air can I get in and get out on every breath. I think it can make a big difference.
Agreed. If you're lucky enough to have good volumes, and you just have an issue with frequency, or you're not accessing your volumes well, all you really need is a metronome. You set it for the frequency you should be breathing during this level of activity, like a zone 2 or a zone 3 or zone 4. Mm-hmm. Set the metronome to that. Try and breathe on the beat as much as you can, plus or minus. I'm not hard on it, because there is a range that you can breathe in. But try and stay around that metronome beat, but maximize your breathing, your breathing volumes themselves. So it's cheap, but you've got to get there first. you have to have good capacity and you have to have good volume to be able to consider doing coordination. Otherwise, all you're doing is coordinating bad volume.
Yeah. Hence the importance of being able to quantify how much you're breathing in, how much you're breathing out, and how resistance is good, but you have to make sure you're moving the right amount of air in and out first. We were talking about low back pain. I know you've, was it your master's that you recently defended and finished?
Yeah, and the master's was huge. So we're just publishing another main author, but I'm obviously a coordinating author for the upper quadrant. So prediction, I'm publishing the spinal, and then there's another author using my data to present the lower quadrant prediction.
Okay. Can you talk a little bit about this injury prediction and prevention? So that was kind of the overall theme of it. Can you kind of talk us through the study that you organized and what the outcomes were?
Yeah, absolutely. So I did this more not as a exercise physiologist or strength and conditioning, more as a physio. So I was a physio in the military. So while I was a regional practice leader for Western Canada for the military, Canadian military, the one thing I noticed over many years of being a physio was the fact that we had high recidivism rates, high re-injury rates for the same condition on the same person. And I get frustrated because of the fact that I believed it was our fault. I believe there's something that we were missing that did not put them at a low enough risk prior to us discharging them to be able to require the same type of injury to cause the problem again, not something less. So I developed what I refer to as the Rehab for Performance program, which is going national in the Canadian Forces, which is a quadrant-based multi-phasic program that runs for, most of them are 8 to 16 weeks in length, depending on the area, to decrease recidivism rates. And what I did was I took my strength and conditioning and my physiology side and shoved it in there and said, we're not giving the tissue long enough with the right loads to be able to cause the tissue to adapt in a way that brings them back to a low risk. We had really good results, so much so, like I said, my program is being continued to be supported and will be rolling out nationally in the Canadian Forces. But then I thought, okay, I had a series of tests that had to be done for baseline and to be able to move between the phases and to be discharged. So that's my normal brain going, okay, I need to know where they are now. I need to know when they're ready to move, because very few people understand the importance of progression. Everybody talks about progression, but they have no idea when to progress. They'll look at a calendar or they'll look at a microcycle or macrocycle and say it's time. How do you know? You test them. So, and then for discharge, to know that they were at lower risk. So we found that it had a profound effect. So I thought, well, these are mainly movement-based tests along with some functional scales. I thought, well, there's got to be a way that we could predict risk in a currently uninjured population by quadrant. And there's been quite a bit of prediction studies that have come out, and it's everybody's favorite thing is to slam prediction studies now. Everybody's become an expert, and I find it frustrating because you should always honor the people that have moved us to this point. And if it wasn't for them, we wouldn't be discussing it in the first place. So, respect to everybody that came before me. You look at FMS, you look at YBT, you look at other methods. Well, these guys set us on this path, and I believe they're absolutely correct. We should be able to identify a person at a higher risk. My issue with the previous research was the ability to predict a particular injury area, because your training will be specific to an area. So if you're just going to tell people that they have, if they score under a certain score on the FMS, they're at a 20% higher risk of injury, where? And did an ankle measure actually predict a right shoulder injury? And Sure, there's lots of physios out there that will tell you that yes, to talk about crossover. Like, no, more specific, more directly. So I decided to do a study that also threw out traumatic injuries, because that was part of the issue, is they were included. You can't predict traumatic injuries. So I threw all those out, and then I wanted an uninjured population. So because they didn't control for that before.
Mm-hmm.
And then, so I looked at 17 different movement-based tests along with the military. I did a full demographic and environmental breakdown. Other people are using that data, so that'll be published in another study. But I wanted to look, obviously, at, I figured that on the hypothesis, that it would be some combination of past medical history, current level of function, and pain provocation, and some kind of movement deficit. And I figured that each quadrant that we looked for a way of predicting would be a combination of those four things. And that's how open my hypothesis was. So we took 495 Canadian Armed Forces currently uninjured people, took them through a baseline questionnaire to look at their medical history and their environmental and demographic history. Asked them to rate their current level of function for any area in which they were injured in the last 5 years. And then we took them through a 13 stage. We filled an entire gym with a staff of about 20.
Yeah.
And put 495 people through 17 different movement-based tests. And then what we did was we followed them for 1 year. For every month, they were sent electronic questionnaire they could answer by email or by text if they were injured in the last month, and they'd have to identify, if so, where were they injured, what was the type of injury, and we also looked at the level of care they required. You know, did they have to report for medical care, or was this something? And we defined the injuries really well, because if you talk about trauma, some people will think, well, that's being hit by a bus, and other people will think, I bent over to pick up a pencil and my back went. That was traumatic. So we had to be able to throw out the trauma, the real trauma. We just called it sudden onset contact versus sudden onset non-contact. Yeah. And that was more difficult than that just sounded to be able to define it. And we only lost, I think we lost less than 7% over the year. Yeah. So we ended up with a very large group. And then we looked at all the univariate and the continuous variables, and we divided into upper quadrant, so neck, thoracic spine, shoulder, arm, hand, versus hip, knee, ankle, foot, versus low back, pelvis, hip. And the physios will understand why the hell I combined those together, because there's certainly a crossover there. Yeah. And then one person took all my data and did their master's or PhD and did a thesis on lower quadrant. One did upper quadrant, and I did spinal.
What were your most? Let's start with the most surprising findings for you. What came out that you maybe did not expect?
Number one that just blows my mind is the fact that if I figured having more than one incident would put you at a higher risk, a significantly higher risk, and it didn't. Huh. You know, if you've had 10 and you've had one, the significance was about the same. It was highly significant that you would have another injury in that area. And that's what's nice, is we didn't cross over areas, but a previous low back injury, more than one was the same as more than 5. So that, I did not expect that at all.
Why didn't you expect that?
I just thought if you've been injured 2 or 3 times, I figured that you'd be just more susceptible to being re-injured again. and it has good face validity, and it gave me comfort thinking this, but it was just like, you're kidding. And all three showed this: upper quadrant, lower quadrant, and spine. It wasn't as if there is one of them did. It was just really funny. Well, as soon as you've injured once. But the cool part of that injury was I used what's called the SANE scale, a single analog numerical evaluation. Very fancy name for a scale that basically just says, well, I'll use it with you. Sean, have you had an injury in the last 5 years?
I have.
Yeah, which area?
Low back.
Low back. Sean, how would you rate your current level of function in your low back from 0, non-functional, to 100% fully functional?
I'd probably say a 6 or a 7.
Percentage?
60 or 70%.
All right. That's the SANE scale.
Okay.
What do you think the cutoff was that would increase your risk of having an injury, a non-contact injury, in the next year?
I'd probably say 80%.
87.5, or we did a cutoff of 90%.
Yeah.
So just asking that question alone was one of the best ways of determining the person's at risk.
That's a pretty powerful question. And I mean, if it's it's pretty significant that you could just ask someone on a 0 to 10 or a 0 to 100, and then if you know they're below 90, then something you have to watch out for.
Yeah. Yeah, you've automatically identified a population in, how long did that take? Less than a minute.
Yes. Well, under a minute.
Yeah, and it requires no special qualifications. You don't need a PhD. You just simply need to say, tell me about your injuries in the last 5 years, and you ask them that question for each area.
Yeah, so for top, for bottom, and for middle, so to speak.
Yeah. So what you would do then is that would give you a direction of focus for that particular individual. And then obviously upper quadrant had different, like if you want to look at the univariate and the continuous variables, there was many that were predictive. But of course, we did a forward stepwise regression to determine the best combination. And there's a myriad of ways of doing this. And what's great is we, like I said, we've submitted, the upper quadrant is being published in the ACSM journal. And we received already an email about how we did the data analysis from a very intelligent group that works specifically on prediction. So it was absolutely wonderful to say, we understand what you did, but you could have done it this way. And we feel this would be a better way of doing it. So we're actually doing that on it as well, to see if there are differences as well, out of respect to the fact that I don't want this important research to not be used because of the fact of a data analysis method, because you can do 1 million of them with SPSS. It's a matter of just plugging a few things change. So we're going to do both and be able to respond to them and say, okay, thank you very much for your feedback. Really appreciate it. We want this to be high quality and to be able to be reviewed by people like you and respect the way that we did it. So we're going to do that as well.
Yeah, that's really great. That study, correct me if I'm wrong, that study didn't include anything about interventions, or did it?
No, at this point, obviously you can see, I started off with the story about R4P. So the concept of, if we can identify a population at risk by quadrant, would a quadrant-based program decrease their risk and result in decreased injuries? Yeah. So it's a very long, but what's nice is, this research starts the basis in which I'm in conversation with another person completing their PhD at University of Ottawa with the military population who wants to use all of this to move to the next level. Yeah. And one day it'll connect. It will connect that, like FMS tried to do this with a score under 14 and less. They proved that they gave a program and it changed their number. with the assumption that it changed risk.
Yeah, the number on the test and the risk of getting injured is not the same thing.
Right. So they didn't complete that. But what is interesting is if in the latest studies it showed, and this is where the pain propagation came in, showed that pain during any of the FMS tests were more predictive than the FMS test itself. And
for future injuries or risk of future injuries?
Yeah, for future injuries.
Yeah.
So it's sure enough, the four that I mentioned all came in: past medical history, current level of function. We just talked about those two. But for upper quadrant, and this is very interesting, smoking, when you think about the thoracic spine and the effect of smoking on the lungs and the ribs and the chest, there was a high correlation that was only smoking in upper quadrant.
Interesting.
Yeah, and it stayed in the model. It was so strong.
Yeah.
And then the good news was it's something that is very, very effective. And I give credit Phil Plisky, but the upper quadrant YBT composite score.
Yeah. Can you talk about it a little bit more?
So are you familiar with the YBT test?
I'm not.
Are you familiar with the star excursion balance test?
By name, but please go ahead and describe it for anybody who might not be acquainted at all with those concepts. Well,
the star excursion balance test was kind of the precursor to this YBT test, and all it was again, it was the FMS guys and Phil Plisky and Rob Butler and Greg Cook and all those guys just doing good work. They've created a platform that you could stand on, that you could easily measure your ability to move in 3 planes of movement maximally without losing balance.
Okay.
So it's a kind of a loaded stability mobility test. It started up a lower quadrant in which they stand on a platform and they move a platform forward as far as they can.
Okay.
And then back into the side and then back and across and switch legs. And there's metrics for each plane of movement.
Yep.
As well as a composite score based upon limb length. Well, after they did this, they created one for upper quadrant.
Yeah.
So you're in a stacked position with your hand on the platform and you're moving your hand in different positions.
Yeah.
And obviously from a functional point of view, it's a very functional position in which you're having to, a huge amount of core and the relation to core stability and function at the upper quadrant. And again, you measure each plane to look for deficits in a plane, and then you have a composite score based upon your arm length. So it's very specific to the individual. Phil and the guys have done a huge amount of work on different scores for different sports, so norms for different sports.
Yeah.
So very easy to do. The test requires just this kit. And we found that the composite score, I believe it was under 100%. It's a percentage score based upon their 3 planes added up, divided by 3 times their arm length.
Okay.
So you end up with this score, was a significant predictor of upper quadrant injury risk. So we know that it resulted in an injury if they scored poorly on it. Now there's tons of really good ones that you would think would fit in there. A lot of there was pain with the upper quadrant, the shoulder clearance test. Any of the pain ones were really good on their own.
Okay.
In some cases they were thrown out in the forward stepwise regression, but good people will look at the individual scores and may incorporate more of the univariate and the continuous tests into what they would use as a screen. And that's what I would do is for the next study would be looking in the case, let's say, of upper quadrant, is I would select all those that were significant and retest the whole thing again with a larger group of people, and be able to define it even more of the test. My goal in the end would be to take the lower quadrant, the upper quadrant, and the spinal, slam it together into a full body screen that could be completed in a matter of less than 20 minutes and give a risk profile for each quadrant.
Mm-hmm.
That would help trainers, performance coaches, physios, athletic therapists concentrate on areas of higher risk.
Yeah. Now, since you're talking about exactly this, concentrating on an area, that implies some kind of intervention. And so from your experience as an athletic trainer, physiotherapist, I mean, you wear many, many hats, Daniel. And that's one of the things we love about you. What, in your opinion, is there a good rule of thumb with all three quadrants that we can go ahead with? Is it usually about increasing mobility? Is it about increasing stability? Is it about strength? A combination of those? What is usually lacking, or what do people usually benefit from the most when they have a restriction in one of those areas?
That's a great question. Of course, the answer is everything. But if I plug in like the R4P program we have for performance, if I built so there was 4 phases for each one, because I had to take them through, again, establishing good movement, and then work them all the way up to maximal loads.
Mm-hmm.
Right. So the phases were very specific to a goal. So the first phase was reestablishing normal movement and uniplanar stability. So then I go biplanar stability, triplanar stability, max loads. Mm-hmm. And that's the way my brain thinks. And I did it for all of them. Mm-hmm. Now the loads, for example, for a lower quadrant would be much more about, at the end, would be acceleration, deceleration, changes of direction, agility, being able to load up a knee that way or an ankle or foot that way. Mm-hmm. So a lot more about that. Fourth was all about pure function. All the programs need to be of significant length to allow the physiological changes that are needed. And that's where the physiology side of me comes out and goes, that's too short. That's not enough loads to be able to cause the changes that I need in the tissue. So I built each of the lengths of the phases were built on the appropriate number of workouts to cause the physiological change. Also, you need to get them to get the neuromuscular learning patterns, and then just plain load to change, let's say, the muscle fiber itself. Mm. So for low back, just going in, and they'd start off with phase 1. The guys that lacked mobility hated the mobility section, but loved the stability section. And the guys that had good mobility to hypermobility, they loved the mobility section, but hated the stability section. So they kind of self-selected, and they kind of told you. It was really easy after completing phase 1 and saying, what exercise do you hate the most? And you could clearly identify where the deficit was. And then
just give them what they don't like.
Right, that's part of it, right? I mean, how often is that true? For
it's so true. Yeah.
Oh, I hate zone 5, and you're going, yeah, well, that's where you need to work. So, and then when they just having those metrics, like they had to meet certain scores, and a lot of the scoring was, well, guess what? I used for upper quadrant as baseline was upper quadrant YVT. Was part of it. The clearance test, almost everything that showed up to be significant predictor as a univariate or continuous was part of my screening process for R4P, for the lower quadrant, for the upper quadrant, and the spinal. And they would change. But I would, if you look at my phase 4 of the levels, my guys are doing heavy squat, heavy dead. They're doing pulls and pushes across the gym floor with the sled. They're doing battle ropes. That's my phase for a low back rehab program.
Mhm.
You know, quit being a chicken shit. If you want to know they're not going to be injured, then try and injure them. And this is where people just, they don't have the guts. You trust your programming that you've brought them to this point. They now can stabilize in a standing position. You throw a battle rope at them, they know how to be able to engage properly. They know a squat and a dead position, so they can drop their hips into a good position. And they can wail away with the upper quadrant to be able to get maximum muscle contraction.
Mhm.
And if they have to ever do anything like that, is they will not be injured because you
Mhm.
prepared them for it. So that's you can look at all the phase fours are absolutely brutal. I use agility ladders for upper quadrant and they have to be able to move in and out of the agility ladder sideways, up and down off things,
Mhm.
all fully loaded, because we know loaded and overhead. Those are the two positions that shoulders break down.
Yeah.
So it's not just sitting there and doing rotator cuff exercises. It's there. I've never understood rotator cuff problems down here. You see tons of people handing out these exercises, right? If I could say anything about shoulders, physios, for God's sakes, people have never come into you and said they had shoulder pain when they do this. So stop training them there. They have trouble up here. If you test external rotators to internal rotator strength here, external rotators will be weaker. If you test up here, internal rotators will be weaker. Test in the right space, train in the right space. You should not be training in a position in which they're not having trouble and they're stable. So we had them do a ton of overhead work, and even throwing a 5-pound ball. I try and hurt them at the end.
Mhm.
Is just be able to go these. When I designed phase 4, I worked with a bunch of other strength and conditioning coaches. That what is the worst thing that people hate the most when they have these injuries? And people, throwing, or being able to do a pull up or a push up. Great, I set that as my standard for discharge.
Mhm.
Let's make them do the hardest thing they could possibly do.
Mhm.
So I think that if we can identify risk by quadrant, and then because they're not currently injured, keep them away from the medical community. It's so much better for them to think of themselves as not being injured.
Yeah, because the
But
psychology plays such a big role as well.
it does. That's part of the reason why I built R4P, was to get them out of the physio clinic into the gym. You are no longer injured. You are now just have deficits that need to be trained. And all you need is the right exercise, the right movement with the right load to be able to change that tissue and to make you functional again. So I really think that a majority of people would just respond really well to being able to know where they need to focus. And imagine if they could do this online, right? If they could just do a series of tests and plug it in on the web and it spits out a program for them. How many people would we stop from being injured in the first place? If you've been injured before and you're sick to death of being re-injured all the time, despite the fact you're doing everything your physio tell you to do, just do these series of tests, do these exercises, and then redo your tests, and we can guarantee you're at a lower risk of injury.
Yeah, that's really interesting. I might have to take you up on that offer, Daniel. Moving.
One of my favorite discussion. I presented an R4P in China.
Yeah.
And who was out in the audience? And I was nervous as hell. Mike Boyle, sitting in the front row, and I'm going, I love Mike Boyle, and I still love Mike Boyle. Michael, if you're listening. But we became friends, and he came up and told me one of the nicest things. He attended the entire lecture, was like 3 hours, and he came up and he said, "That's the best lecture I've heard in the last few years. You're on the right track. Keep going." And then he wrote me about a shoulder injury that he continued to have, and he followed my R4P program and did really well with it. This is Mike Boyle, So I think the trick is, let's keep people out of the medical system because it's already overloaded. It's expensive, and stop thinking that they are not in control of improving themselves. I think that's one of the coolest things, is the fact that, you don't need to see anybody else. You just need to do the right things and get rid of some fear associated with some people, especially around the low back. There's a lot of fear avoidance. There is a portion of education that needs to be done with that population to get them to understand that they must not fear pain. But we can identify those people ahead of time using a couple of different questionnaires. So if we don't have to put everybody through it, but if they have high fear avoidance, then we understand that there needs to be a conversation about pain so they understand it better. So
I think that's very true. I mean, for myself and my low back injury, for the year, I guess there was the traumatic injury, let's call it, and then there was a period of, I was working a lot, I wasn't sleeping much, I just couldn't find the time to get back on top of it and recover. But then there was a long period of avoidance, of being afraid of moving, and that just kept it going for a very long time. And since the beginning of this year, when I really started to actively try and move more in that area, move more and better, things have come a long way. I'd probably say that in January I was probably at a 30%, 25% maybe on function on my low back. And like I said before, I think 60, 70 right now is pretty accurate. So I'm not fully there yet, which is why I said I'll probably have to hit you up for that 4P program. But it's the fear of pain and the fear of movement itself. Kinesiophobia, I think is what it's called, is such an important part in that. So that's definitely an ongoing topic for myself. Daniel, I want to move on and talk about another thing you did this year, because it's been a really busy and big year for you. You presented at the Moxy Summit 2021. So can you talk a little bit about what you presented on, and then maybe if you had a chance to watch some of the presentations that went down, and what stuck out for you as being maybe really interesting or something to follow up on in the coming months and years?
Yeah, I would have liked to have presented for about another hour and a half, because it was really hard I didn't have enough time to really be able to fully explain the way that I would have liked to in a 30-minute spot. But it was going back many years ago. I presented on combining Moxy and metabolic analysis data.
That's how I found you. It's still on the YouTube. I always refer back to it. It's on the Moxy Monitor YouTube channel. Go check it out. Go watch it. It's a fantastic presentation. Go ahead, Daniel.
Thank you. I'll have to redo that one, the full one, and just when I have a couple hours, just like blast out a whole, say all the things I would like to say.
Yes. Definitely, please do it.
Yeah. So I love Moxy. The near infrared spectroscopy is a great way of looking more directly at oxygen delivery and utilization at the tissue. That's what I love about it, which on metabolic analysis, it's probably one of the weaker things that you can look at. Although, looking at, I'm finding new metrics which really clearly define, and I've got to write on this too, that clearly define areas of efficiency and inefficiency. Like if you're using metabolic analysis is great for finding fat max and crossovers for the lower zones. It gives you all the breathing frequencies so that you can see changes in breathing frequency based upon changes of fuel source. But it's all based upon what you're breathing out. It's not directly at the muscle. Whereas near-infrared spectroscopy gives you that data of what's happening right then at that muscle for both oxygen utilization and a surrogate for delivery. It's not really delivery, but it's a good surrogate for delivery. And so I wanted the presentations on focusing on the benefits of adding a second metric, but having to know how to be able to combine the two of them together. And the added strength of being able to look at, for example, elevations in SMO2 will give you very clear ideas of zone 1 because you're delivering more oxygen than you're utilizing. You can correlate that beautifully with decreases in RER on metabolic analysis indicating a higher fat utilization. So it's an affirmation, and it makes your determinations that much more solid.
Mm-hmm.
But when you get to the top, you're just looking. I've been teaching a lot of people look at VO2 over BF, which very few people use. But you can look at your ability to use oxygen per breath. In areas in which the people don't train significantly, you see large decreases in efficiency. In other words, you'll see the milliliters per breath drop. That's brilliant. It tells me what's going on systemically. But the ability of using the NIRS to be able to see whether they're capable of utilizing the oxygen being delivered or not, and what's happening with blood flow. The issue with and I have to point out that the issue with Moxy is without the breathing data, you don't know whether utilization is a utilization issue or whether they're hyperventilating and you're running into an issue with the oxygen not being able to offload. An unloading problem, not a utilization problem. It's kind of there's a two-parter there.
Right.
The inability for it to unload into the cell for it to be used. So it was more of a, hey, metabolic analyzer guys, use Moxy to supplement your information. Hey, Moxy, be very careful about your determinations. Yeah. And then I presented a bit more on how to identify a respiratory limitation and the fact that it's trainable. Mm-hmm. So that it was nice to present on, but honestly, I could do a whole series on this, and I kind of have a bit with the metabolic analysis course.
Yeah.
There's a lot more on it, and module 4, which I'm writing, and I've just reached out to Roger for their support, and Evan, because I want Evan to do a presentation on near-infrared spectroscopy and resistance training.
Yeah.
It's not my bailiwick. He's just a star. He's absolutely amazing. And I'll present on my years and years of experience with metabolic analysis and for testing and training. Mm-hmm. But Evan will present on how to use it. So it'll be a big push to those that have learned a lot about metabolic analysis to start using NIRS. Mm-hmm. And I'm hoping that it'll go the other way. The guys with the Moxy devices will be stimulated to know more about metabolic analysis and be interested in completing my education as well.
Yeah, I definitely think that holds true. I mean, for myself, maybe having gone the unconventional way around, which is I had the Moxy first, and then I went around and got a VO2 master, and now I'm able to look at least the respiratory data, and now adding other things like, I mean, the spirometry that you've recommended to add from the beginning, and then now looking at other metrics that are, I think, very interesting, like heart rate variability thresholds, and like you said, not looking at one or the other, but really just looking at all of them. And that's now how I conduct my interpretation. Is I have all my data that I collect from the test. I go through each graph or each parameter that I want to analyze, and I make an interpretation of that parameter. And then I have kind of a somewhere where I conglomerate all that information that I collected, or that all my interpretations go into one spot. And then I look at, okay, what's the average of those, or where does it make sense to put this one? Where does it make sense to put threshold 1? Where does it make sense to put threshold 2? And then that allows me to, even though it's not going to be perfect because I am missing CO2, I'm probably missing other things as well, but actually looking at all the data as objectively as possible and trying to zero in and kind of triangulate into finding those important inflection points in the data. And I think that's definitely the way to go forward. And I look back to a year ago when I had one Moxy and, kind of bet the house on that one thing. It's definitely it's one point of data, right? Like you said, it's one point of data, and you have to take it for what it is. And you cannot bet the house on that. And you have to have, if you have more Moxys, great. But if you don't have the respiratory data, that's a big missing piece of how somebody behaves, especially when we're talking about, longer events, longer endurance type efforts. we have to look at all of this together. And then ideally, then if we can even talk about having a physio flow to look at, cardiac output and those kind of things, I think that's definitely where things are looking, to go for me in the future, to again add more things, but always come back to the centerpiece. So that's really interesting. Did you get a chance to look at any of the other presentations at the Moxy Summit?
That was tough because I'm in the middle of the move to England.
Right. Yes.
And so actually I was giving the lecture as we were packing up the house. I had only my desk and a laptop, and everything else was being loaded into boxes. So I didn't get a chance to catch too many others. Their lineup is just getting better and better and better every year.
Mm-hmm.
And I'm thrilled to see the number of, and a nice combination between the academia,
Yep,
and what do you call us? The rebels.
I don't know, field people.
Yeah, I would consider us the leaders. That's what's funny is we'll let them catch up and do the legitimate research behind absolutely everything later. But somebody has to be able to go, this just doesn't make sense, and to throw out questions that other people wouldn't throw out, like using metrics like VO2 over BF is just not something a lot of people have used. I think it's really valuable after 30 years of staring at this stuff. And being able to combine, I made a comment to an athlete this morning. I was looking at their data and their crossover is 165. And I said, I don't want it that high. And it was just that response of what? I thought we wanted as far as we went to the right. And no, I don't. As a coach, now I go to my fourth spot and go, no, unless I want you to finish last, because you're going to be super slow. So I've got to move that to the left to be able to create a better 3, 4, and 5 for you. And then being able to understand, now you're using the physiology and your results to actually for race preparation and for strategy. And that's the cool thing, is once you get really good at this, you can be able to go, I can play with respiratory frequencies and volumes at different intensities to be able to improve performance, not their performance and their physiology, but actually manipulate during a race to beat somebody else. And there's very few people right now that are understanding how to use their physiology and their advantages to beat somebody else. Mm-hmm. So I think that's another direction that we can go.
Yeah, that's definitely, I think, the next frontier. But what I would say to that, and tying back to your metabolic analysis certification program that you built for PNOE, you have to know the rules before you have to learn the rules before you learn to break the rules. And so, talk a little bit, just to finish here, Daniel. Talk a little bit about this program. Like I said, I've been going through it, and I plan to do a little review video once I'll be finished going through the first 4 modules. Like you said, you're still writing module 4 right now, which is the advanced concepts in metabolic analysis testing, nutrition, and training. First 3 were foundations in exercise physiology, metabolic testing and data analysis, nutrition and exercise prescription. So can you talk again about, the overall idea with this course? From what I can tell from the outside, it's probably everything that you've learned in your decades of practice, in all the different, wearing all the different hats that you do wear, and then trying to synthesize all of this in a very rigorous way, which I'm really, really enjoying so far. But I'll give you the floor to talk about this to finish the call here.
Yeah, it's definitely a labor of love. Doing this for 30 years and being able to combine all your knowledge into a system. I think that's, my brain is very good at building systems and seeing patterns. And so it was really nice to be able to say, well, if I'm excited about more people doing metabolic analysis, but I desperately don't want them to do it even the way that they teach at university. No, we can't continue to do it this way. I understand why universities do it this way, so they can publish and compare, but it's not how we do it on the ground. And so what I wanted to do is say, well, I have a chance of influencing how the data is used with this device. and present and get rid of some myths and concepts that are time to kill. So I thought really it's my chance to influence where we're going in this particular field. And it's a great honor to be able to do that. And I'm certain there's people that disagree with me about certain things. And what's great is I'm very happy to discuss it. But the concept of taking them through, of understanding physiology, but not system by system, but understand how complex it is, but not to overwhelm them, but just to understand how many interactions are going on at once and what the priorities are. And I'm even finding new ways of saying things now. Right now, it sounds funny after all these years, I'm telling people the purpose of your training is to decrease the kicking in of your extended governor model. I've never said it that before.
Yeah.
But essentially, all your training is about making sure none of these switches turn on.
Yeah, delay the moment where your brain is just going to start restricting things because it feels threatened for one reason or another.
Right. And we have those chemoreceptors and mechanoreceptors that are just picking up all of the information. Just keep that information level below the point that in which the brain thinks there's a risk to a vital organ. Mm-hmm. And you go, that's a much better way of describing what your training is supposed to do, and learning where that edge is and pushing it to the right, where you can work harder without that alarm bell going off. Mm-hmm. So I'm still learning ways of communicating this in a way that people would understand more simply. And then the second is just, there's so much information from metabolic analysis that's thrown out, and it used to drive me crazy. I get to discuss myths like anaerobic threshold and VT1 and VT2, and even the relative unimportance of VO2 max. That's amazing. As the head of science and education for metabolic analysis company, was sort of like, these are interesting, but they, avoid any metric that involves one number. One of my rules is if it lands and said, well, your fat max is 119. Oh, no, it's not. I mean, there's an area in which you're using fat more than others, and that's the area that you should quit using these single number things. They're made to be lazy and comfortable and to fit into algorithms. It's meant for math people to do stuff with. It's not meant for science people to be able to go, I can see a consistent trend here that changes, and that's what good scientists will do. Mm-hmm. And let's leave the math to the mathematicians, and we'll concentrate on the other. And then I would want to ask you, module 3 just kills a bunch of myths. What do you think of the nutrition and training? In particular, I wrote a large part of I wrote all of the training side of the lectures. What did you think about the concepts on training?
Well, I was fairly well acquainted with your approach on training and approaching training from different zones, from the many calls that we've had, especially at the beginning of this year. You and I consulted a lot. For the audience, I consulted with you quite a bit, with probably upwards of 10 hours spent looking at data alongside you, trying to figure out, how do you look at the data? What is meaningful for you? What do you see sticking out, and how can I learn from it? So I think all the training zones I was well familiar with, but it was great just to see you integrate all those different moving pieces. The nutrition I have to review again. But definitely looking at, all the endurance training, the interval training, the resistance training, the respiratory training, taking those categories and then making sure that going back to the basics, look at the program, what is missing, and that's something, again, from you, that pre-test questionnaire is just pretty much where I get most of my information. The test itself is fantastic, and I love all the tools, and I love looking at the data and being able to report and tell the athlete what is going on, how they're breathing, how their muscles are working, et cetera, but just looking at their program as objectively as possible and saying, hey, you're not doing this, do more of this. Just back to what you were saying before, if they don't like it, it's likely that they need to do more of it. And then really kind of coming back to basic principles of having a good balance in your program, checking all the boxes, making sure that you're doing the heavy resistance training, making sure you're doing the interval training, making sure you're doing your fundamental endurance work. All of this is it's always a good reminder, because I used to, I guess, more than now. I like to think, at least, I used to get lost in the minutia, and you would go to extreme lengths to find details and figure out, okay, is it really this fraction or the other fraction? But really, if you just zoom out and just keep a bird's eye view on things and try to stay objective in what you're looking at, this helps a lot. So I think for me, that was probably the most interesting part, is just reminding me of, okay, you have to just step back and look at everything. And again, yes, look at your data, look at the different data points, look at the Moxy, look at the breathing stuff, but don't get caught up in one or the other, and really just I guess, just stay as objective and holistic in your approach as possible, versus adhering to one approach or one system or one method or anything like that.
Yeah, I think it's well said. I tried to look at it and say, again, what are all the options of training that are available, and how do I identify who needs what when?
Mm-hmm.
And that's essentially, if you don't know that, you don't know how to design a program. So that ability to be able to say, okay, resistance training is important to somebody who has a relatively slow metabolic rate, low skeletal muscle mass, and demonstrates a strength deficit during an active test with a goal that is requiring increased strength. So you just go, okay, are those things in place? Otherwise, resistance drops, right? Do they have a respiratory limitation, which I tend to kick to the top because it has so many profound effects on cardiovascular and metabolic? And is their CV system fine? That's the only way that you can train, but you do need to keep their race goals in there.
Mm-hmm.
And trying to get people to understand that it's your race goals, your race plan needs, and this is where coaches need to learn how to incorporate a race specific program with this person, because they don't. They just put out an algorithm for a 26-week Ironman and just hand it to the person and say, well, hopefully your zones are right. And because it's January, we're going to do base. And you're going to go, that's horrible. It's so disrespectful. Like, you have no idea whether their base is fine. You don't know what their deficits are. Sure, they need to do the mileage necessary to build the mental confidence that they're going to be able to do it. They need to get better at transitions. They need to be able to put the load through the muscle and the tendon and the bone. There's that side of the house. They need to be able to handle the heat or the cold or the elevation. That's coaching. But what about that guy? Where does he fit in? Does he play any role in your decisions? Or you basically just go by a calendar and just do everything by that? So I'm really hoping that coaches can see we can improve how they work with their programming so much more just by doing a good test and providing them that here's the deficits for this person. And this is where we recommend they're starting now. Go ahead and plug them in your algorithm, but they might start week 6 on you, or might start week 12, or they might make you have to do a little bit of work and build an individualized program rather than punching out algorithms and charging people a huge amount to basically something that you created 3 years ago. So I really hope that coaches see this is accessible. There's people out here that will do the testing for you and provide you the information necessary to truly bring your coaching game up.
Mm-hmm. No, I fully agree with you on this, Daniel. Man, it was a lot of fun to have you back on the show. Where can people find you, Daniel, if they don't yet follow your work?
Well, you can get a hold of me through my company, which is Strategic Sport Performance, at strategicsp@icloud.com. Or you can get a hold of me if it's reference PNOE through coaching@mypnoe.com. And if you're in England, I live in Chichester, and I've had all kinds of invites to do site visits and courses. So I look forward to it. And if you're interested in the metabolic analysis course, then you can go to www.mypnoe.com academy, and you can learn a lot about my course there.
Fantastic. I'll put the links in the show notes. As always, Daniel, thanks again for coming on the show for the third time. It was a great pleasure.
Thanks, Sean. Always a joy.
Take care, man.
Ciao.
Thanks for listening to this episode. If you would like to support the podcast, please take a few moments to leave a written review and a 5-star rating on Apple Podcasts. If you want to watch this episode again, you can find the full video recording on my YouTube channel. You'll also find hundreds of hours of free content, all my podcasts, my thoughts of the day, structured presentations, and more. So don't wait, go subscribe, and I'll see you in the next episode. Take care.